Should we record it internally as well? Guess we don't need to if it's just going straight to Facebook.
Yeah. Absolutely. Okay, well, you know about here.
That's a. Oh my God, this is like between two ferns.
Yeah. You can hold on to your soda.
Yeah.
Say?
You can hold on.
Oh, it's okay.
Okay.
Feel
So
free
feel
to grab
free
a
to
seat.
sit down.
Okay, thanks.
Good morning. It's our privilege to have Dr. John Street from the University of British Columbia visiting us this week at the Seattle Science Foundation. And we've tried to get some of his wisdom and sagacity poured on us over the last day and invite the viewers to send in any questions they might have. Dr. Street is an expert orthopedic spine surgeon and operates capacity and at the same time has a very strong academic presence. So welcome, John.
Thank you very much. Thanks a lot.
So just to get us started, what first got you interested in orthopedics in general, and then how did that evolve to spine surgery?
I actually started out after med school. I went into general surgery training, and I went through the full program of training in general surgery, and then found that I just wasn't really satisfied. I didn't get that sense of being able to see a result of fixing something and being able to move on. So I'd always been impressed by the orthopedic guys when they would come to emerge and realign fractures and how quickly they seem to be able to get people back on their feet and moving. So I, after the general surgery, I went back in and did a training program in orthopedics. And then as I was going through orthopedics, I found that I had some exposure to spine surgery, and I found it really challenging to understand the anatomy and really complex patient presentations. And I kind of was drawn to that challenge. I thought, you know what, better to have a job that challenges you every day than to be coming in and doing kind of the same thing in such a repetitive fashion. So that was kind of what brought me to spine.
Okay.
Almost by accident, I think.
Okay, well, accidents that result in some of the best outcomes, right?
Yeah.
So tell our viewers a little bit about your training, where that happened, where you went to med school, etc.
So I went to medical school in University College Cork in Ireland between 1987 and 1993. So medical school is a 6-year program in Ireland, and you go to med school directly out of high school. So there's no undergrad first. So finished med school, then did my general surgical training, took my exams in that in 98, and then at that time when I had that kind of awakening and that I didn't want to do general surgery, I applied to get on the orthopedic program, but I was unsuccessful because I'd had no prior experience working with the orthopedic guys. So at that interview, the senior orthopedic guy interviewing me said, you know, you've got to go away and do something a bit different that sets you aside from the other guys so that you can get into orthopedics onto the training program. So I took 2 years out and did a PhD in basic biology of fracture healing, and then submitted that thesis, and then with the publications that came with that. That was kind of the leverage I had to go to the interview for orthopedics. Orthopedic training in Ireland is 6 years, and so I completed that training, took my exams, and then came to Vancouver, BC in 2005 to do a spine fellowship with was primarily Marcel Dvorak and Charles Fisher were the leads at that time. And I was in the right place at the right time.
Sure. Those are pretty powerful names in the field of spine surgery.
I was a senior surgeon there, was retiring, and I was the fellow at the time, and so my timing was very opportune, and so they offered me a position there, and we've been there since.
Awesome. Awesome.
Dr. Tubbs, we have a question. What kind of, or what got you into the spinal injury research that you are currently doing?
John, would you like to lead off?
Yeah, my interest in spinal cord injury research is around clinical outcomes, and particularly trying to identify if there are any modifiable things that we can work on that can improve the outcome. And so it's around identification of complications and then mitigation against those. I think that the drive for that was really patients advocating for themselves, saying, you know, it's why do I have another pneumonia? Why do I have to have spasticity? Why do I have neuropathic pain? And then understanding how much of an impact those things were having on quality of life after the injury. That's really what stimulated me to do that.
I think for me as an anatomist, and I work with pediatric neurosurgeons for 25 years, we made good progress in better identifying anatomical structures and translating that into clinical practice. A better understanding here helps clinically. The one thing that our research had trouble bridging was spine and spinal cord injuries. They're so devastating, and especially in a young patient, their whole life changes. So I think after years of exploring the human body from head to toe, that's one area for a clinical anatomist that's still ripe and in need of further investigation, looking at the intricacies of the spine and spinal cord, and how can we not only better understand them, but how does that information then act as a springboard for surgeons like yourself to then treat those patients and give them a better quality of life than what they currently have.
And where do you both see the field of spinal cord injury research headed?
So
in the near future, and then maybe distant.
For
Repeat the question.
yeah, where do we see the field of spinal cord research heading? I think up to date it's been fairly primitive. I think John might agree with that our understanding is really the very tip of the iceberg, and even with all of this understanding, translating that into patient care hasn't helped very much. I mean, our knowledge doesn't allow us to make people walk again, more or less. And I think we're at an interesting juncture in the field of technology and medicine. So it's just at this point, maybe in year 2017, where we have new technologies, new therapies, new ways of diagnoses that will allow us to potentially start treating these patients with spinal cord injuries. And that necessitates a better understanding of the spinal cord than what we have. And Dr. Street, I think, again, will concur that our overall basic understanding of the brain is much more advanced than our basic understanding of the intrinsic microarchitecture of the spinal cord, and therefore it's a opportune time for us to address that with additional studies.
Yeah, I agree. I think that there has been a long history of like basic science and animal type studies looking at spinal cord injury, and rather than actually finding a solution or an answer, what it actually uncovered was so many questions that we don't understand about the anatomy, the pathophysiology of a spinal cord injury. And so, yeah, I agree. I think we're at a very immature time in our understanding of it and being able to apply treatments. I think that probably one of the most innovative things now is not necessarily cellular manipulation of the injury, but facilitating movement with whatever spinal cord function remains. So exoskeleton type research, I think, because that's facilitating, that's using what remains of neurological function and translating that into a greater functionality and capabilities for the patient. I think it's a very exciting time for spinal injury research in general, in that we're getting to the place where our understanding, I think, is going to allow us to ask the right questions to be able to find some new answers. But I think the last 25, 30 years has been a learning process to get us to that point.
Right.
Can you talk more about the exoskeleton type, the exoskeletons that are emerging?
So there are some technologies that will facilitate upright posture and movement in people who have spinal cord injuries whereby they don't have sufficient motor strength in their lower extremities. And the aims of them are obviously to provide that upright posture, because that helps with many physiological activities in your body, maintains your bone strength, but also then locomotion or movement. And in general, I guess there's passive type of devices where you sit in the device and it moves the body. They're obviously less physiological than the active ones, which pick up or take an existing neurological function and then translate that by increasing the torque or the force, the movement created by that electrical stimulation to move an exoskeleton. And so it's a different way of looking at, or a different approach, I guess, to the research for spinal cord. So rather than, like I say, how can you change the damage that's done within the cord, this is moving it more down the functional line, and particularly if you can enhance what neurological function might remain.
Well, it's exciting. It's almost science fiction. 5 years ago, this would have been in a movie theater, not here in practice. And even in Seattle, we have some of the robotics and exoskeletons that are being used to treat patients with incomplete spinal cord injury. And the idea being, historically, that the therapist would take the weakened or the withered extremities from the spinal cord injury and work them for the patient who had very limited function, trying to maintain that motor tone. And now the new paradigm is that we're trying to, through the exoskeleton, encourage and retrain the brain to do that for the patient themselves. So it's a different strategy, and it has some, based on some very preliminary studies around the world, including here in Seattle, we are finding some exciting, improvements in these patients.
In regards to a rehabilitation center, what should patients be, what should patients be looking for in a rehabilitation center?
So for patients after they've had a spinal cord injury.
Yeah.
There's many aspects to patients' needs and patients' extended family needs after a spinal cord injury, and so if you're looking to see, does a rehabilitation center fit your needs, you've got to look at what do you as an individual need, what do you need from what does your social structure, family support need, because it's more than just the physical rehabilitation. That's obviously key, and most centers will have a dedicated staff who's experienced in the physical rehabilitation component. It should also have the other aspects other than just locomotion or movement in the limbs, but you want expertise in sexual function, you want expertise in bowel and bladder function, expertise in skin, and also then the psychological support that's required. So the facility really should have a comprehensive team that involves all of those aspects. Rehabilitation groups that are actively involved in early post-injury care, I think it really helps the transition for the patient, the individual is injured, into rehabilitation. So we're lucky in Vancouver that all the patients who have a traumatic spinal cord injury, they're seen and assessed and by our rehabilitation specialists while they're still on the acute care ward, typically a week or so after their injury. So the transition into rehabilitation is already facilitated very early on, and then that allows the patient and their family to make those connections to that later. So they would be some of the things that I think would be important.
Great.
And going off of the rehabilitation question, do certain types of spinal cord injuries sustained lend themselves to better or worse rehabilitation?
So in general, the prognosis for neurological recovery from a spinal cord injury, there are some factors that we know predict the likelihood and predict the magnitude of neurological recovery. And probably the most important predictor is how badly injured your spinal cord is at the time of your injury. And it makes sense, the more badly, or the greater the injury at the time of the acute event, then, and the more complete the spinal cord injury is. So by complete, we talk about how much motor function remains, how much sensory function remains in the distal extremities. The greater the injury, the less likely there is for significant improvement, and obviously the lesser the injury, the greater the improvement. Certainly one very, very key factor is if an individual has an incomplete spinal cord injury where there is any remaining motor function, and that's significantly different from an outcome perspective than if there is no remaining motor function.
The other thing to add is when you speak to lay people, they often don't understand levels of the spinal cord, and the essence is the lower down on the spinal cord your injury, the less profound your neurological outcome. If you have a higher spinal cord injury, so say the neck, then you're going to have a worse injury, and you're going to have more parts of the body that don't work. So positioning is also something to take into consideration.
And obviously it's very case by case basis, but do you have any personal experience with how patients can better improve their like independence and gain more function from what you've seen in that?
Yeah, I have to say that we treat about 150 spinal cord injured patients a year, and there's very varied personal psychological reactions to that injury, and I've witnessed two of what I kind of thought were almost extremes of response. I recall a physician who was downhill mountain biking and had a very devastating high cervical or neck injury with no remaining function in his arms or legs. And it was clear fairly early on that that injury was not likely to improve over time. And he really struggled with accepting that injury, and for months afterwards wanted to be allowed to die because of how bad the injury was. Now he's 3 years post-injury. He's using a ventilator at night, but not on the ventilator during the day. He lectures at University of British Columbia in the medical faculty, and he's almost independent in all functions during the day. So an extraordinary transformation from a really, where he really struggled early on with that response. The other is an individual who was, he was a young guy who had taken a year off of his college education to hang out in Whistler and ski and do downhill mountain biking. And he had been skiing and had a really bad injury to his upper thoracic spine. So his arms were still working, but his legs weren't working. And my apologies, it was a downhill mountain bike injury. 3 days after his surgery, he was sitting in his bed with his laptop on Craigslist, and he had just sold his downhill mountain bike and purchased a downhill mountain bike specifically made for people with spinal cord injury, because he knew what he wanted, and he wasn't going to let this injury change, or at least he was going to make sure that the amount of his life that had to change and his lifestyle that had to change, he was going to minimize that as much as possible. And so a very different initial reaction. And I think that's one of the greatest variabilities that I've seen in the injuries, is that initial response.
John, what do you think about mechanisms? So here in the U.S., motor vehicle accidents would account as the biggest offender for spinal cord injury. I assume it's the same in Vancouver.
It's interesting. It had been the same in Vancouver up to about 2 or 3 years ago, and I agree that the motor vehicle accidents typically where there's some, it's either loss of control, is it not wearing a seatbelt and getting ejected from the vehicle. There's circumstances around why that can be such a devastating injury. In BC now, the commonest form of spinal cord injury is an incomplete spinal cord injury in the elderly, where they fall from a standing height, but they've got really bad arthritis in their neck and they get a spinal cord injury. That's actually now our most common mechanism.
Wow.
But you're right, typically if it's a high velocity injury, so motor vehicle accidents or some form of high-speed downhill activity like skiing or mountain biking, that usually will mean the injury is of a greater extent than if it's a lesser velocity, a smaller trauma injury.
Out of curiosity, how many spinal cord injuries do you see coming from downhill Whistler skiers?
So we certainly have a seasonal effect. So in the summer, we will see probably one spinal cord injury a week from downhill mountain biking, and then during the winter, it's probably one, maybe two from skiing.
Wow. And the mechanism or the location of those injuries, how often do you think they're, so skiing, cervical, thoracic, lumbar versus downhill biking?
So the skiing is almost always thoracic. So their arms will still work after the injury. If there is neurological problem, it's in the legs. The downhill mountain biking is typically cervical. There is some work being done by some of the biomechanics guys who share our ICORD research center in Vancouver, and they're working on developing braces that you can wear in downhill mountain biking that stabilize the neck to the shoulders, so that if you are traveling at high speed and you do have a really awkward fall, if you are going to get a spinal injury, it's probably better to get it lower down than higher up. So they're trying to design bracing mechanisms that will take that force that would otherwise have been applied to the neck and try and either dissipate it or bring it down lower so that it affects the lower part of the spine.
What percent of the downhill bikers do you think are odontoid fractures?
We rarely see odontoid fractures in that mechanism. I mean, odontoids we typically see are in elderly. Low trauma. Most of the downhill mountain biker injuries that we see are facet fracture dislocations, and I don't know if that's related to helmets, type of helmet, whether they wear a brace or not. We certainly know that there's been a reduction in cervical injuries with the introduction of some bracing, and it's interesting. We've lobbied some of the groups or the owners of these downhill mountain biking parks to try and have them push for their riders to wear braces, but that's a difficult challenge.
It's a high risk sport,
and people know what they're doing, because most mountain bikers that we have treated with spinal cord injury know mountain bikers who've had a spinal cord injury.
Sure.
That community will be relatively small, and they'll know people who've had the same. So I think that they're aware of the risk.
What about another topic, Canadian football? I mean, how often do you see spinal cord injury from that group in Canada?
That's very rare. Yeah, I have not in 11 years in Vancouver. We have not treated a single CFL player,
Interesting.
and we haven't treated a single high school or college player with a spinal cord injury.
Interesting.
I've seen some college footballers who come because they've had one or two or more episodes of a stinger, so a sensory deficit from a cord
Brachial
injury.
plexus, yeah.
And that's always a challenge because these are young kids, often on scholarship to college, who really, really, really want to play football. And they may have discs in their neck or bone spurs in their neck that are pressing against their spinal cord, and so you know that they have a increased risk of an injury if they continue to play in that sport.
Sure.
And that's often a real difficult discussion to have because, you know, it's not easy to convince them to give up their football career, but you also want them to appreciate the additional risk that they play at.
It's always interesting to me, coming from a peds background, that we would see, you know, incomplete spinal cord injuries, and then see those patients in follow-up, and without doubt, usually the father would ask, when can he go back and play football? That was the first question. Not is, are his legs going to work?
Outside of trauma, what symptoms should people be aware of that could indicate a compromise of the spinal cord?
Well, anatomically, everything that goes to your brain and comes from your brain goes through the spinal cord, more or less. So if there's any change in neurological function, it could potentially be the spinal cord. And then you have to leave it to your, you know, physician or healthcare provider to determine if it's one of three things. It's going to be the spinal cord, it's going to be one of the nerves that come from the spinal cord, or it's going to be the brain. So they'll help you localize it and then come up with the best diagnosis treatment.
Yeah, and I think it's important to reiterate that the presentation can often be very complex, and big nerves in your legs or arms, a problem with that can look like a problem with the spinal cord, can look like a problem with the brain. And it often takes, you know, well, it certainly will take your physician to go through that with you and go through a really thorough history and physical examination to be able to work out which of those it is. They can often overlap very easily in a clinical presentation.
Right, and the way we're put together, for better or for worse, is in a complex way, so that the spinal cord is basically an elevator going up and down. There's some fibers that come from the periphery for your sensation, so if you're able to feel on the skin, that's ascending up the spinal cord, right? So they can be selectively injured. Then you have descending fibers from the brain that are going to make parts of your body move. They can be selectively injured. And to complicate that even more, those fibers don't necessarily stay in the same place as they're moving through the cord. And some of them have a particular pattern where they cross over. They're in two different areas. So it really takes a professional who has expertise and examination of the nervous system to be able to pinpoint where the problem is.
And then one of the last questions that we got from others, unless you'd like to prompt anymore, how best can healthcare professionals and families best care for their loved ones or patients with a spinal cord injury?
So not necessarily the individual is injured, but the healthcare professionals and their family.
Yeah, how can they best?
I think understanding or trying to understand what it is that individual needs at that time. Because there's, like any devastating episode, there's almost like the different stages or processes of grief that have to be gone through to overcome an injury. I've seen times where patients want to know everything about their injury in the most minute detail, and other times where it's, don't tell me anything, I just want to get better and move on. And it would be wrong of us as healthcare professionals to think that we know what the patient wants to hear. And the family will obviously have a better understanding because they'll be closer to that person, they'll understand them from a personality point of view. I would say, don't be afraid to ask the injured person what they want. What do you want right now? Is it more information or less? Is it how do you want us to help you? I've seen families struggle where opening up the conversation is really difficult, because to open up the conversation you have to accept the reality, this new reality of the injury, and so that can be very difficult to do. But unless you get past that point, the family will continue to struggle because they don't know if they're doing right or wrong. The injured individual struggles because they're not getting the support that is really important to them at that time. And you certainly don't want to fall into the trap of having off discussions between the healthcare professionals and the family that don't involve the injured individual, because that can cause lots of difficulties later, because now you're introducing a potential of the injured person now may no longer trust their healthcare team because they've had offline conversations with the family, and vice versa. So I think really working hard at opening up and then maintaining the communication.
We got one more question. Someone was told that they have a better chance of getting an exoskeleton covered by insurance if they have a T7 and below injury. They'd like, if you have any ideas why, or for example, if a T6 injury wanted to get approval, they could.
I don't know the answer.
I'm afraid I don't know the answer to that. No. I mean, not all injuries are amenable to exoskeleton type of supportive treatment, and not all individuals would be, even if they had the same injury type or same level or even the same extent of motor deficit. So I think it's very, very individual based, but whether there's a distinction made from an insurance perspective, I don't know.
Great. Well, John, thank you very much. It was great talking to you, and I'm sure the viewers have enjoyed hearing and getting some of your expertise for themselves.
Thank you very much. Thanks for your time. Thanks a lot. Isn't it interesting, the questions that get generated?
Very interesting.
Yeah.